We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, FAPIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Welcome back to the Infection Connection. I am Nikki, your infection prevention enthusiast.
And I'm Jess, your co-host and fellow germ wrangler. So, Nikki, did you hear about the infection preventionist who tried stand-up comedy?
Oh, no.
Turns out their punchlines were just as effective as their hand hygiene protocols, clean and to the point.
That's my Jess. Woohoo! All right. Well, speaking of clean and effective, we are excited to dive into today's episode with not one, but two amazing guests, Dr. Terri Rebmann and Dr. Ashley Hughes, whose work is revolutionizing infection prevention training. They have been instrumental in studying how infection preventionists tackle the unique challenges of training in diverse healthcare settings.
That's right. Dr. Rebmann, director of the George Mason University School of Nursing and a leader in infection control for nearly 30 years, is here to share her expertise. And Dr. Hughes, a human factors psychologist and associate professor at Case Western Reserve University, brings a wealth of knowledge about health information technologies and care coordination.
Yeah, and before we jump in, we'd love to give a special nod to Dr. Janet Glowix, whose expertise with the CDC's CDC's Project Firstline and passion for connecting with frontline staff shaped the foundational work behind this study. And she was unable to be with us today as there's a mandate on CDC employees talking to the media. So it turns out infections aren't the only thing being prevented. Now let's get started.
Okay. So, Dr. Rebmann and Dr. Hughes, thank you so much for joining us today.
Yeah, it's great to be here with you.
Yes, thanks so much for inviting us.
Absolutely. We're so excited to have you guys. So let's kick things off. Your research surveyed over 2,400 infection preventionists, which is incredible. What inspired this work?
Well, the COVID-19 pandemic posed so many challenges to infection preventionists and to IPC in general. There were challenges like healthcare staff turnover, changes in priorities due to the crisis, burnout, and just a lot of other factors. So CDC's Project Firstline team wanted to gauge what was happening with the IPC field during the latter part of the pandemic, so in 2023. And they wanted to find out what were the challenges that IPs were facing, how much and what types of IPC training was happening at that time, and what IPs would prefer to be doing in terms of training versus what they might be doing. So they partnered with FAPIC to conduct the study.
Yeah. So one of the key findings was a strong preference for simulation-based training among the infection preventionist, which I think is fantastic. Love simulation-based training. But it's not widely used. Can you talk a little bit about why you think there's a gap between it being the preference and it not generally being the practice?
Sure, that's an excellent question. And I don't think infection preventionists, especially during the COVID-19 pandemic, are alone in this preference. But given that the survey took place during a period of time during the pandemic, resources were just completely strapped. And one of those resources, obviously, is time. So I think with time and competing priorities being part of what may have prevented some use of simulation-based training, there's just also, you had a lot of new IPs entering the field for the first time. And in addition, I think we'll discuss this a bit later in today's episode, but sometimes people think of simulation-based training as needing high, very costly or high-tech equipment, but that's not always how you have to do simulation-based training. So I think there were just a couple of motivating factors, especially during the pandemic, that may have prevented them from using that, even though we know it's effective and a good training method.
So, for listeners that are unfamiliar with simulation training, can you explain what it involves and why it's so effective?
Sure, absolutely. So part of the reason why simulation training is our preferred go-to for improving anyone's knowledge, skills, or attitudes is that it gives the opportunity for practice in using some of those key skills. So using practice in some type of high fidelity environment, or even through a low fidelity simulation scenario like role play, it gives people the opportunity, especially frontline healthcare workers, to see, for frontline infection preventionists, to see how they're actually applying some of these techniques, such as hand hygiene, and be able to give them some guided feedback while they're actually demonstrating those skills. So yeah, it's a very effective and powerful tool. Thanks for that question.
So I think this is fantastic. I am a huge proponent of hands-on learning and also the simulation-based training. And also, I think you have to make a really valid point around being able to provide the feedback during that return demonstration portion. But let's get practical now and talk about some of the simple things that healthcare facilities can do tomorrow to improve infection control training.
I think it's a great question, right? It's kind of like, where does the rubber meet the road? I would encourage infection preventionists to take advantage of the CDC Project Firstline materials and tools. They were all produced by a team of experts in the field. They're all free of charge. And there's really no reason for infection preventionists to try to recreate the wheel. IPs are so busy with other priorities and tasks. So I say, go to the CDC Project Firstline website, and that has links to tools created by professionals with CDC Project Firstline partners. Download and use those materials and tools. Again, they're all free of charge, and they're all evidence-based.
So, your study mentions just-in-time training, and I keep wanting to go back and clarify things for the listeners. So, for those that are unfamiliar, what does that look like in a hospital setting? What does just-in-time training look like? And is it particularly useful for nurses with limited time availability?
Oh, that's an excellent question, Nikki. So just-in-time training, just as the name suggests, is training that's delivered in the nick of time. So it can be a very practical way of delivering training. If you notice that hand hygiene numbers are slipping in a given unit, you can respond by helping boost those skills before those numbers create some type of adverse patient outcome or infection outbreak. So just as the name suggests, it's training that's delivered just in time as those skills are beginning to degrade. Why it's so useful, especially for nursing staff, and why I think so many of our infection preventionists really relied on just-in-time training is that you need to have your attention split in an infection prevention role and wear many different hats. So when it comes to just-in-time training, it is just a way of helping you stay on top of those skills that may be lagging behind with certain frontline staff. And that happens to all of us, right? I forget things, you forget things, we all forget things and need helpful reminders. So just-in-time training is just a really nice, semi-convenient way to do that.
If I can just tag on to that, thank you, Ash, for that description. Another way, back when I was an IP many years ago, what I use just-in-time training for would be when I was out doing rounds or out interacting with the healthcare staff on the areas that I covered. If you observe an error in IPC practice, just-in-time training isn't as formal as that sounds. It literally means interacting with that healthcare professional in the moment and saying, hey, I saw that like this happened. Let's talk about what the proper maybe PPE to use in this situation would be, or maybe you need to add this step to that practice. So it's intervening, that impromptu training that you're providing in that moment to engage with that healthcare worker.
And that can be really difficult, I think, for staff because they feel like they're being police and jumping in where they think it might not be their field of expertise. So that can be really hard. And I think having this support can encourage that. Hopefully, I don't know. What do you guys think?
Yeah, I think this, and part of our research findings actually backs this up. So one of the findings from the study was that IPs that had more experience or that were CIC certified were more likely to engage in this just-in-time training. And that to me makes perfect sense, right? Like in order to do that impromptu training, that just-in-time, you see something that an incorrect behavior and you want to intervene, that requires critical thinking, deeper expertise. You have to be able to think on your feet, and you have to interact with that healthcare worker in a professional way. So this is not about, we're not talking about publicly shaming someone for doing something incorrect. It's engaging a one-on-one conversation with someone and saying, hey, I saw you do this. Here's the proper way to do this. Like, we're all in this together. We are all trying to prevent HAIs. And so engaging with that healthcare worker in that way can, it takes the heat off of them. So they don't feel like you are trying to publicly shame them or pointing out an error. Everyone makes errors. And healthcare staff they're very tired. They have a lot of priorities. It's easy to make a minor mistake. So pointing that out in a non-shaming way, it can be very effective.
Yeah, so that's fantastic. And one of the, speaking to your point about engaging with the staff, one of the things that my leaders have frequently talked about is to come from like an inquisitive perspective rather than that you did something wrong. So I think that, that piece about being engaging and trying not to be the police is really critical for that just-in-time feedback. But
Right.
For facilities that don't have access to high-tech resources, how can they still make these trainings engaging?
Right. And, I think this gets back to our initial topic for training, which is, relating things to the current environment where the IP is practicing and the frontline nurses or the frontline staff are practicing, and trying to make that very relatable and engaging. So it would be kind of nice to have a blend of these just-in-time training with a simulation or a practice component, to be able to observe in a non-judgmental way, offer some solutions or corrections to that person's workflow or how they might incorporate, different PPE or whatever the recommended adjustment would be, but to be able to help demonstrate that and guide the frontline staff through that process.
I love how you said incorporate too, because I don't know about you, Nikki, but what I often hear is it's just one more thing we have to do. So
I hear it all the time.
Right, right. And that's what you don't want this to feel like. It should be natural to be a part of your everyday work, to have a safe work environment. And that is what everyone wants, not just for preventing HAIs, but obviously for patient safety. And with that goal in mind, it's important that those modifications are going to be easy and sustainable as much as possible for the frontline provider.
So your study also referenced the APIC competency model. How does that help infection preventionists choose training methods?
Yeah, so educating frontline healthcare workers on IPC is included in multiple domains within the APIC competency model. And that makes sense, right? Because it's patient safety is at the core of the APIC competency model. The model itself doesn't help IPs choose training methods. It's simply noting that healthcare workers need to be educated so they feel empowered to take the appropriate actions to prevent HAIs.
And more experienced and certified IPs were more likely to provide formal training. How can the newer IPs gain the skills to implement these methods?
That's a great question. Newer IPs really need to embrace and engage in continuing education opportunities so that they continue to improve their knowledge, their skills, and their competencies. And this can be done in a variety of ways. So newer IPs can attend the National APIC conference or local conferences, participating in available webinars. APIC and other organizations have great webinars free for members, and really just any other educational programs that are offered locally, regionally, or online that's going to help those newer IPs really gain proficiency in IPC. I also believe mentoring is really critical. So, in my opinion, newer IPs should identify formal and informal mentors in the field who can help those newer IPs gain those critical skills and knowledge. And one of the things that I have loved about IPC, I have found the field to be so warm and welcoming to newer IPs. I know I personally learned a lot from the mentors that worked with me when I first got started all those years ago. I encourage other new IPs to do the same. You learn a lot and you make really incredible, strong friendships.
And for those lone IPs out there at, the critical access or community hospitals that may be the only IP, do you have any recommendations for where they should look or reach out to find a mentor?
Yeah, I think getting involved in your local APIC chapter is an incredible way to find those mentors. So I started practicing IPC in St. Louis. And so we had some IPs that worked in more rural areas that were part of the St. Louis APIC chapter. So they were able to find mentors in the greater metropolitan area, even though those mentors might not be at their facility or necessarily even directly in their community. But they were able to partner with those individuals that had more experience and more knowledge and years in the field. So that was very effective for them.
That's great. Thank you.
So, yeah, that's an interesting view. And I want to agree that the world of IPs is always so welcoming, warm and welcoming. And I want to switch gears a little bit here, but I noticed that simulation ranked high in preference, but very low in usage. And I'm curious what strategies or technologies could bridge that gap.
That's an excellent question. And it's one that ties back to some of the findings that Terri had mentioned. So, we did find that the more experienced and certified IPs were more likely to provide these formal training. And so with having more of a simulation training or simulation-based training approach, that tends to lean toward the formal side, as we were discussing earlier, doesn't necessarily have to be. It can be a role-playing type of situation during a one-on-one sort of just-in-time training event where you can give that individual or group an opportunity to practice those new skills, to get some type of feedback or to brainstorm ways to better improve their workflow in a very safe and meaningful manner. But when it comes to simulation, I think it also gets back to the idea of tying back into some of what CDC Project Firstline attempts to do, as well as tying into your community of infection preventionists. So what I mean by this is that there are opportunities to learn more about simulation training and what it entails, how you might be able to use what resources are available to you. As I mentioned earlier in this podcast, you don't need high-tech these virtual reality components to be able to do simulation-based training exercises. At the heart of the activity is really that practice, being able to practice and get feedback on what exactly you're doing. So I think being able to have a model for train the trainer for IPs would be most valuable. And that's something that we have discussed with CDC partners.
And as you're talking about the interactive tools and the availability and, maybe they're not all available to everyone, but Nikki and I were interested in hearing about what you think the most innovative tool or technique is that you've observed as part of this process.
That's a great question. There are two for me that come to mind. One, Mass General Brigham has developed a free virtual reality IPC module aimed at clinicians. I believe it's aimed at nurses and physicians primarily. But the program walks the individual through a realistic healthcare setting, and you have to interact with the system and identify infection risks. And then there are also a number of IPC-related tasks that have to be completed, like hand hygiene, proper use of PPE for different tasks, respiratory etiquette, cleaning and disinfection, that kind of thing. So that is a very innovative, interactive, free tool that's available that I really liked. Another one that I was impressed with was University of Washington has developed I believe it's called TIPS, the Training Infection Prevention Through Simulation, Train the Trainer course, which is free of charge. Both of these programs, I believe, were developed in partnership with CDC Project Firstline, which would make sense. But they're both evidence-based, developed by experts, interactive, great for IPC, and free. So I would encourage IPs to take a look at those tools and see if they can incorporate those into their training programs.
Okay, so we can't get out of any conversation without talking about the pandemic, which you also highlight the challenges of. What lessons can we apply to ensure that training stays a priority during crises?
That's a fantastic question. And we know it's just a matter of time before the next crisis occurs within that affects IPC. So one of the things that we learned during the pandemic, that we've learned during other past natural disasters and infectious disease disasters, is that infection preventionists become overwhelmed with the amount of work and competing priorities that pop up during these events. And so training can sometimes be put on the back burner because there are other priorities that might rise up. However, training is very, very critical, especially during a pandemic where infection prevention is so critical to minimize HAIs and maintain patient safety. So a tool that APIC developed, actually the APIC Emerging Infectious Diseases Task Force developed, was the APIC IPC Acuity Scale. So it's a free tool that's available to help prioritize IPC work. So the way the tool works is you categorize the different tasks of IPC, and it ensures that the critical work like surveillance and training, especially event-specific training, still not only occurs, but is being done by an IP, and then less critical tasks that normally an IP would be doing, but during the pandemic or during a crisis, maybe that task is less important. So it can either be reassigned to a non-IP staff member, or maybe even put on hold until the crisis is over. So we know training is going to be critical during a pandemic or other future events. So it's really important that we do have trained IPs producing and continuing to deliver that training. But IPs don't need to do all of this alone. I sort of mentioned this earlier. I think IPs really need to take advantage of these existing IPC materials that were created not only by CDC's Project Firstline, but there are other free educational training and tools that are available by partners such as Mass General and the University of Washington. So we're all in this together, but we have to, really prioritize that IPC work to be done by the IPs.
Well, Dr. Rebmann and Dr. Hughes, this has been a really interesting and insightful discussion, and we really want to thank you for being here with us today and sharing your expertise.
Thank you so much for having us. It's such a pleasure to talk about that study, but also just to talk about IPC training and future directions for the field.
Absolutely. And, before we go, we always like to ask, is there one thing you'd like our listeners to take away from today's conversation?
I guess just reiterating, IPs are so busy. and don't have time to recreate the wheel. So please take advantage of those free materials that are available from CDC's Project Firstline and from Project Firstline partners. It will make your job easier. They're evidence-based, they're free, and it'll give you more time to focus on other aspects of your work.
Yeah, I'm hoping that funding for Project Firstline continues.
You and I think all of us can agree on that as well. And yes, it's been wonderful to share some of the insights from this particular project, but also just to highlight some of the challenges that IPs seem to be facing as well. Sometimes when we ask about training, we learn about other challenges that involve just having the time to train. So just reiterating Dr. Rebmann's message to get connected, get support, and get some of the tools that are freely available to you.
Thanks so much. And remember, the best infection control strategy is teamwork and maybe a cheesy joke or two. Ba-dum-bum. So thanks for tuning in to the Infection Connection. Stay curious, keep those hands clean, and we'll see you next time.
That's a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the FAPIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.